So I'm one of the thoracic surgeons here. Compared to my other colleagues, we don't have any newfangled catheters or devices that we can place into brain, kidney, or liver to be able to take out pulmonary metastases. We're kind of old-fashioned thoracic surgeons. I will demonstrate or talk about some other techniques that we're using besides the old-fashioned thoracotomy and spreading the ribs in order to take out some of these pulmonary mets. I do not have any financial disclosures. So actually the first metastasectomy that was performed in the lung was actually back in 1882. And it was well publicized by Alexander and Haight in 1947. And from that series of criteria is even used to this day to actually determine exactly how to control metastatic disease of the lung. First is control of the primary tumor, which is of course, of most importance, and then absence of any other extrathoracic disease. Now, this is a little bit of a caveat, especially when it comes to colorectal cancer, because we can sometimes do minimally invasive procedures along with our liver colleagues in order to rid patients of disease. And then after the operation, make sure that patients have sufficient pulmonary reserve. With new techniques in thoracic surgery, we're actually able to perform this a little bit better. And so in terms of indications, just briefly, we're using CT scans now with 2 millimeter slices, able to detect 20 to 25% more nodules than conventional CT scan. In addition to that, there's been some question. With pulmonary metastases or metastasectomies, one of the key surgical techniques were to actually place your hand into the chest cavity and to actually fill the lung. Now, because of the new imaging modalities, this is not necessary anymore, and that's allowed us as thoracic surgeons to replace open thoracotomies and sternotomies with minimally invasive approaches such as video-assisted thoracoscopic surgery. What about the use of PET scan and helping us with pulmonary metastasis? Not really. The reason why is because for lesions that are small, less than 7 millimeters in size, really can't see that too adequately on PET scan, and so therefore direct visualization, typically with the thoracoscope, is actually pretty helpful. In terms of resectability, it's really not that easy to define. Some patients are actually pretty good candidates. Some, for example, the case that you presented in terms of the patient who's had a previous right upper lobectomy, sometimes in those particular situations, we may be able to do a VATS procedure on them in order to find the actual lesion and also be able to resect them. Patient characteristics. We need to make sure first that they can tolerate an operation. Of course, someone who comes in who's on 5 liters of oxygen, on a lung transplant list, with metastatic lesions, I know that's, not that common, but those patients aren't really the best candidates for an operation. Yet, we're able to get some of our lower pulmonary reserve patients through minimally invasive techniques with minimal morbidity and mortality to the patient. And so that's why thoracic surgical evaluation is actually very helpful, especially in those patients in which you're thinking about doing some form of metastasectomy. Number of lesions. The number that's thrown out there is 3. Anything more than 3 or 4 actually has a 33% higher relative risk. This was based on a study. It was an international pulmonary metastatic study that was performed in 1997 out in London. And from that, they determined that 3 was actually the magic number. Have we pushed the limit? Yes. I've resected, and my other colleagues have resected lesions from like 5 to 7 out of patients as well, as long as they're peripheral, safe, and also that you have a good clean margin. What about locations? Yes, it's helpful to have a lesion at the edge of the lung. That's extremely helpful. It's almost like a chip shot for us. We'd be more than happy for us, to do that. But at the same time, there are other lesions that we can also resect that are actually deeper in the lung. We could do minimally invasive procedures such as upper lobectomies or segmentectomies without having to perform a pneumonectomy in order to help rid these patients of disease. Also, what's important, and again, difficult to determine, what is the disease-free interval? Most studies talk about 1 to 3%. Have we cheated? Yes, we have. What's the best way to actually determine that? Well, I think a multidisciplinary approach in terms of how the patient's doing, other evidence of disease, and what their primary disease was like. And then tumor type, that is also very important as well. The first case that was ever discovered or kind of talked about when it comes to pulmonary metastasectomies is osteogenic sarcoma. These folks love having their lung taken out because they actually have a long 5-year survival and also long cancer-free survival. So these people are the perfect setup in order to do a pulmonary metastasectomy. More than 10 to 20% of the patients will have a pulmonary met at the time of diagnosis. 85% of the patients at some point will ultimately develop a lesion. In addition to that, chemotherapy does not help with osteogenic sarcoma. That's where we come in. There is definitely a clear benefit. Like I said, 3 to 5 year survival, 45 and 38%. And then second and third metastasectomy, it's still about the same. So these folks do extremely well. What about soft tissue sarcomas? Not as good as osteogenic sarcomas, but still decent. 5-year survival after pulmonary metastasectomy is about 22 to 36%. You see better survival after leiomyosarcoma, not as much with our synovial cell sarcoma or any of our peripheral nerve sheath tumors. Colorectal carcinoma is also another lesion that we also look at as well in patient populations, especially in folks who also have liver mets as well. With RFA and also minimally invasive technique in the liver, in addition to a minimally invasive pulmonary technique, these people actually have a very good 5-year survival. 74% of the patients will relapse after the first resection. About 20 to 30% of the patients can actually undergo a second resection. The reason why it's such a lower number, because when they come back around the second time around, there may be other form of disease elsewhere that has not been established. Melanoma is becoming a very popular topic for us, especially in our clinical scenarios. Only 10% are actually candidates. The reason why is because at the time of thoracoscopy, there's usually other metastatic disease along the chest that's not really picked up by imaging modalities, such as PET scans or CT scans. Probably in about 50 to 60% of the time do we actually see not extrathoracic disease, but intrathoracic disease that's actually more severe than what's actually depicted on the CT scan. 5-year survival is actually pretty minimal, 7 to 25%. So it's not the best when it comes to actually a pulmonary metastasectomy. These patients must be evaluated appropriately. In addition to that, it doesn't hurt to actually take a look inside their chest to determine if they can have a metastasectomy. Yes, with minimally invasive approaches, doing an open look is not as significant as it once was with open thoracotomy. We can stick a scope in, take a look around, and the majority of the patients, if we do not perform a pulmonary resection, they go home within about 12 hours after their operation. Renal cell carcinoma also was in conjunction with osteogenic sarcoma as one of the first lesions to actually be looked at for pulmonary metastasectomy, but because of advances in immunotherapy as well as with chemotherapy, surgical approaches in selected patients may be appropriate, but in the majority of folks, they actually do better with a multi-modality technique. Head and neck cancer, I kind of want to actually put a big question mark by this. The reason why is because it's hard to tell in some of these patients whether or not this is actually a primary lung cancer versus actually metastasis from their head and neck cancer. So that's kind of hard to tell. How do you determine that? I'm not quite sure yet. We're still kind of in the infancy stage of trying to actually make that determination. But those patients that can actually tolerate a pulmonary resection, we actually give them the benefit of the doubt and actually think that they may actually have a primary lung cancer versus a metastatic lesion, depending on the stage of their primary head and neck cancer. But again, we take each patient as they come. So the methods in which we do our operations. So back in the early days, back when they had initially discussed pulmonary metastasectomy, up until probably the 1990s, the biggest thing to do was actually bilateral thoracotomies. Unfortunately, with that operation, that kind of raised a lot of eyebrows, especially with the medical oncologists, because you have patients that now can't breathe, now have bad pain, and they can't go on to further systemic therapy, and so folks are not even referring patients for pulmonary metastasectomy. So thoracic surgeons had to be a little bit more creative and actually determine exactly how to best get patients through a metastasectomy. What about a sternotomy? That's reasonable. Believe it or not, it's only just breaking a bone. Yes, people look at us cross-eyed and say, you know what, that's a big bone to break and that hurts. But at the same time, if we look at some of our sternotomy patients, they're able to get out of the hospital in about 3 or 4 days, again, with minimal morbidity and mortality. The morbidity associated with the sternotomy is down to about 3 to 4%, and the mortality is less than 1%. Yes, it's muscle sparing. With a thoracotomy, you're actually breaking the latissimus muscle, you're spreading ribs. In terms of with a sternotomy, you can actually fill both lungs adequately. You have simultaneous inspection of both lungs, and it's still a very popular opinion. Again, though, patients don't want want a large incision on their chest, or are there any other options that we can do? So, video-assisted thoracoscopic surgery, minimally invasive surgery, 2 or 3 small incisions on the side of the chest, whichever side that you're going to go on. Through those 3 small incisions, we can go in. We can actually visualize the lesion. We have other methods and modalities that we can use to actually feel or palpate the lung. With CT scans, that helps us to be able to accurately predict exactly or determine exactly where some of these lesions are. And some of these smaller lesions that are less than a centimeter in size, we use methylene blue dye with the assistance of our radiology colleagues to actually mark some of these lesions so that these could be resected. These patients go home within 24 hours after a pulmonary resection. We can do as much as a lobectomy and also a bilobectomy and pneumonectomy through a video-assisted approach. Again, hospital stay between 2 and 3 days. They actually go home sooner, go back to work sooner, and they also improve their long-term quality of life. It's actually more than 100-fold better than that of a thoracotomy. We can also do video-assisted thoracoscopic surgery on both sides at the same time for patients, and they actually do very well. So, in terms of surgical goal, surgical resection should be minimized, lung parenchyma should be preserved, but we also have to make sure that we carefully select our patients appropriately for pulmonary metastasectomy. So let's talk about a case. We have a 65-year-old lady, non-smoker, presented with pain and left liver lesion and liver lesion in 2003. At that time, it was identified that she had intrahepatic cholangiocarcinoma. She underwent a left hepatic lobectomy, T2N0M0, and she did not receive any adjuvant chemotherapy. In 2009, she had a little bit of thickening in the gastric cardia. PET scan confirmed FDG uptake in this area. Long story short, she was identified to have adenocarcinoma along that area. She underwent a partial esophagogastrectomy with a nodal dissection and intraoperative radiation. 2012, she came back, and she had this. So, she has, if you can see, 3 lesions. One that's actually pretty sizable in size, 1.2 centimeters in size on the right side. Let's see. Yeah, that one right there. You also have another one here that's extremely small and also not as close to the edge of the lung parenchyma down in the left lower lobe. And then she has a third smaller lesion that's down here. So what would you do? I'm going to kind of open this up to the audience. What's the best way to proceed? Any thoughts? I'm sorry? Of course not. That's what you say. Our colleagues, do you guys have any thoughts?
So when was the original diagnosis? 4 years ago?
4 years ago, 2001, if I remember right. 2003. So it's a bit ago.
Yeah.
So she's had, pretty long, life. And, now again in 2009, she had a, recurrence, if you want to call it, whatever. And she had a larger resection. And now, 4 years ago, or 4 years after, now she has these 3 small nodules. I can argue with you and say that, you can make an argument and say, you may have missed this one on one of the past CT scans because it's so small. Who knows? But that one's there. That one's very small, so who knows? What to do? Do we want to do RFA, radiation, or resect them? Try to see what we can do with the pulmonary. So, just kind of make this short, what we ended up doing was actually taking her to the operating room because we didn't have a diagnosis. And because of the lesion itself, PET scan wasn't that helpful in terms of determining whether or not that was PET avid or not, because it was kind of warmish looking. We talked to our radiology colleagues to determine what would be the best way to diagnose her. And, trying to stick a needle in that would have been next to impossible because it's close to the diaphragm, number one, and also it's about less than 2 centimeters in size. And so you're going to believe a negative diagnosis. So we went ahead with the right VATS procedure and actually resected that lesion. It did come back as a cholangiocarcinoma. Okay, what about the other side? In addition to that, we also looked around on that right side and did not see any other lesions whatsoever. She went home in less than 24 hours after her first operation. She did absolutely well. And so now she's in our clinic staring at me saying, what do you want to do about my lesion on the left side? Think we should take it out? So,
let's talk about first ablation of some of those things. Actually, the lung is one of the areas when they're so small, they actually can't be ablated. You actually can't get in them.
Okay.
So ablation would not be an option. They're so peripheral, so they're very accessible to another VATS.
That would be. Any other modalities you could try?
I mean, you can think about radiosurgery, but
Okay.
you know, there are a couple of lesions. Localization of those lesions will be a bit of a problem. We put fiducials in, and and you potentially could do that. I must say I'm a little less enthusiastic in a patient with a cholangio with 3 lesions to proceed like that.
So we only found, well, I'm going to argue with you and say we only had 1 on the right side. So she really doesn't have 3, but maybe just
Well, 2 left. She had 3.
That's right. So I would agree. Lesion on the left is extremely small. It would be difficult, first, to get a biopsy, number 2 for RFA, and number 3 for radiation. So she is on the schedule for another VATS procedure on the left side to try to identify that lesion and also to wedge that out. And then we'll see how she does. What about the role for lymphadenectomy in these patients? And so that's a little bit of an argument or a discussion that we have when it comes to thoracic surgery, especially with either breast cancer or melanoma and pulmonary metastasectomy. There's really not strong literature or evidence based to show that lymphadenectomy or even a lymph node dissection or even lymph node sampling within the chest itself has either been helpful or hurtful to the patient. I think in this particular patient, it would actually be very beneficial to help with, I don't know, staging, even though you've already staged her as stage 4. So would it help with any other chemotherapy? I don't know the answer to that.
I don't think it would help stage the patient in someone who
Of
has
course.
metastatic disease.